Sorry for the slightly late start, but see how long it takes us to get through tonight's lecture. Tonight we're doing abdominal and GI injuries. Um, we've been over a lot of this already in the past, but we're going to be looking at this from a traumatic standpoint, not necessarily a medical like what we did in Module 3. Some of this chapter is going to be a little hard to swallow for people, especially if you've ever been victim to sexual assaults or anything of that sort. And it's a hard thing to talk about. Sometimes it's a really hard thing to hear, um, but it is something that we deal with that is a lot more. It should not be common at all. It should never happen. But unfortunately, even beyond that, it's a lot more common than I ever thought it was. So we're going to be talking tonight about the different types of injuries that we have. In the style of how this module has gone. We started at the head. We then went to the neck, then the chest. Now we're at the abs. We're going to do the GI tract and everything, reproductive organs and what can happen to them. Some things that we need to be aware of as EMTs, both on the traumatic patient care of how do we fix this or at least stabilize them to get them to the hospital. But just like in the medical chapters, we're going to be talking a lot about, I want you to think about this not just as a clinician, but think about this also as one human being to another human being that may have had a very traumatic experience. So this is one of those chapters where um, just keep that in mind, right? We're talking about people sometimes at their worst possible moment, things that have happened that are beyond anything they've ever expected. And even if it's not a case of assault, just an injury there from any source is high anxiety for men and women. If something goes wrong, if you take an injury in that area, like a real injury, it's very much as much of a mental issue as it is a physical one. Let's go ahead and get started. We're going to start at the abdomen and we'll work our way down through the pelvic region as we continue on tonight. So the abdomen is a major body cavity. This extends from your diaphragm to your pelvis. So basically, remember your diaphragm and your bottom ribs are pretty much at the same level. So your abdomen is going to be everything that doesn't have ribs in front of it. Let's see, can y'all hear me? Let me type to Donna real quick. Yes, maybe. All right. So getting back to it, we as EMTs, we divide the abdomen into 4 quadrants, and most of your organs are going to be stored there. Now, I realize if any of you have gone through an actual college anatomy class, they divide it into 9 quadrants. It looks like a tic-tac-toe sign drawn over your abdomen. But for us, we just 4, because a lot of times we're more concerned about hurry up, get them to the hospital kind of thing. So your higher levels of care, say like the ICU or something, they may look at the 9 sections where you have top right, top center, left right, all that stuff. But for us, it's just 4. It's important for you to know the anatomy of the abdominal and pelvic cavities and where organs are located. So understand the functions of the organs, understand where they're at. That way, when your patient is saying, "Ow, it hurts right here," you can start to narrow down what it is that you're having the issues with. Significant trauma to the abdomen can occur from blunt trauma, penetrating trauma, or both, just the same as anywhere else in the body. Depending on what is causing the penetrating trauma, you may have an injury that is just right there around that entry wound. It may be something that is massively, like the entire quadrant's messed up because maybe a guy shot with a high caliber round or something of that sort. 10% of all trauma patients have some form of genito-urinary tract injury. And something that I want to kind of point out here too, one of our biggest concerns that is, well, I'm sorry, not the biggest concern, but one of the things we miss the most as EMTs, as responders, even at the hospital level, is the potential for sepsis. A lot of the injuries that happen in this area traumatically are going to wind up causing some kind of fluid dump into your abdominal cavity, not just blood, but you may have bile from the liver. You may have, you know, different things come out of your appendix or your spleen and all these different organs that have some really toxic stuff inside of them that is fine as long as it's in that organ. But if it gets loose into your body, then it's going to be causing a whole lot of other issues. So for your anatomy review, like I said, we divide your abdomen into 4 quadrants. All right, the quadrant location of bruising or pain can delineate which organs are possibly involved in that traumatic injury. And your quadrants, they all intersect at the belly button. Some organs that are commonly found in your right upper quadrant is your liver, your gallbladder, the duodenum of the intestines, which is kind of the beginning portion of them, and the small portion of your pancreas. For your left upper quadrant, we have your stomach and your spleen. Your spleen looks, it sits kind of similar to how your liver sits. It's just on the other side. For your left lower quadrant, you have your descending colon, left half of your transverse colon, a whole bunch of your small intestines. Right lower quadrant is the rest of your intestines, the ascending colon, and the right half of the transverse, and your appendix. So the big thing that I want you to know of these, of all the stuff that's listed, know where the liver is, know where the gallbladder and the pancreas are, and most of all, as far as your lower quadrants goes, just know where your appendix is at. When it comes to your intestines, um, just know that they're down there. But I don't really care if you get your transverse colon, your ascending and descending colon mixed up or whatever. That's not that important. But definitely know where your appendix is at. I know it doesn't say it here, but your kidneys are in your upper quadrants. So your left kidney's in the left upper, obviously your right kidney's in the right upper quadrant. The only real lower quadrant organ that you're going to pay attention to is your appendix. All right. So it says here your right lower quadrant is common location for swelling and inflammation. The big thing being the appendix. That's why I want you guys to know where that's at. Is because a lot of times when this is the kind of patient you're going to, we want to try to decide whether or not it's the appendix. There's a couple different ways to do that. We'll talk about rebound tenderness, where when you're palpating that area, when you press down, the pain gets a little bit better for the patient. And then when you let go, the pain comes back with a vengeance. That's called rebound tenderness. Something that a lot of, like, well, I say a lot, but something that paramedics will do that you guys is a better way, is better for your patient, is tap them on the bottom of their right foot. It's much less damaging, it's much less painful, but if they do have a swollen appendix, they're going to feel that. So you get the same benefit, the same diagnostic decision as you would be by checking for rebound tenderness without giving your patient extremely excruciating pain. All right, I'm glad you can hear me now. Sorry, I don't know what was going on before. A lot of times it winds up being connection based wherever you're at. Hollow organs and solid organs are in your abdominal cavity. So for the hollow organs, you have stomach, intestines, ureters, and bladder. These are just not solid, right? So think of it like your stomach is a pouch to hold things. The organ itself is hollow, even though you've got stuff in it. The hollow organs, I'm sorry, most of these organs contain food that's in the process of being digested. Urine, when we talk about your bladder, or bile. Bile is created in the liver, but it's not stored there. When these rupture or lacerate, the contents will spill into the peritoneal cavity. So this is where we concern ourselves more with infection than we do with blood loss. I mean, there can be a pretty good amount of blood loss if you rupture one of these organs, but a lot of times infection and sepsis are going to be the main concern. Uh, this can cause an intense inflammatory reaction and possible infection. Peritonitis is an inflammation of this type. Usually it winds up being very painful. And if you don't get it treated, if they, for whatever reason, say it's an elderly patient and they are fighting you tooth and nail on going to the hospital, this could kill them. So this is one of those things where, no, it's not a heart attack, but you want to kind of treat it as such. And if you can do anything to convince them to go, convince them to go. Because peritonitis is a slow, painful death. You'll die pretty quick and painless from a heart attack, but if you're going to die from sepsis due to a ruptured organ, that's a bad way to go. Intestinal blood supply comes from the mesentery, which is folds of tissue that connect the small intestine to the abdominal wall. Patients with injuries to the mesentery can bleed significantly into the peritoneal cavity. The digestive tract gets a lot of blood because there's a lot of it, right? If I can recall right from Bill Nye the Science Guy when I was a kid, your small intestine stretched out would cover, I think, 9 football fields if they were to be lengthened out. So, there's a lot of blood supply for that. If you do have problems with your intestines, some signs include abdominal rigidity and periumbilical bruising. That's going to be from the blood loss that is just pooling up into their abdominal cavity. The solid organs, to the right slide. All right, so the solid organs are what you see on your right. So you have your liver, spleen, pancreas, and kidneys to be solid organs. These organs perform the chemical work of the body. They'll make enzymes, they'll clean your blood, energy production, and because of their rich blood supply, if these break, you will hemorrhage. It's going to be severe. Not whereas your hollow organs are you're more concerned about sepsis and things because of contents leaking out. The solid organs have a very, 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 very rich blood supply, and that's going to be your concern. If somebody actually ruptures their spleen, for example, not only are they going to lose a lot of toxins into the body, but the amount of blood vessels that go through there, because that's your main filtration system for your entire blood supply, the amount of blood that you're going to lose into your abdominal cavity is that severe. It actually trumps the risk of infection. Abdominal injuries are considered either open or closed, just depends on what happened to them, right? And we're talking about trauma, so a lot of this is no different than any other chapter we've talked about in this module. We're just looking at this in a different part of the body and how we're going to treat it. So starting with closed injuries, blunt trauma to the abdomen without breaking the skin. Some MOIs include a steering wheel, bicycle handlebars, motorcycle collisions, falls, blast injuries, pedestrian injuries, and compressions. Seat belts are really bad about causing blunt force trauma to your abdomen. The airbags can do it, especially if you're riding a little bit higher. So you're a vertically challenged person and you keep your seat up high so that you can see over the dash, over the truck, whatever. You run the risk of getting hit more in the chest and abdomen by your airbag than you do in the face. But yeah, a lot of the abdominal injuries that I've seen in vehicle accidents, for example, have come from the seatbelt. Which, I mean, the alternative is much worse, but that doesn't mean you're going to walk away without some injuries. Compression injuries are typically caused by a poorly placed lap belt. Creates an injury pattern called a clasped knife injury. So it looks like a knife, like a pocket knife that is halfway open because of the nature of the seat belt, right? You got the one that goes across your lower abdomen, and then the one that crisscrosses over your abdomen and chest. The bruising is gonna look like that. Deceleration. So if your vehicle hits a tree, you and your vehicle are both driving at 70 miles an hour, for example. You go off the interstate, your vehicle is going to stop when it hits a tree, but you aren't. You're going to continue to travel at 70 miles an hour until you hit the the steering wheel in front of you, the dash, the windshield, the tree itself, depending if you're buckled up. And then once your body stops, your organs are going to continue until they slap into the front of your skull, the front of your ribs, all that stuff. So everything is going to continue moving until it hits something. And because of that, your patient is going to have a slew of injuries beyond just what you see on the skin. Pain can be deceiving. A lot of times it's going to be diffuse in nature, especially if it's an organ. Because remember what we talked about at the beginning of the class, your organs have fewer nerve endings. So the pain receptors that are going to pick up that something is wrong may be further away, and it's going to make that pain feel a little bit diffuse. If they are hurting and they can specify exactly where the pain is at, then you're most likely looking at muscle pain, abdominal wall pain, that kind of thing. Blood or fluid in the peritoneal cavity produces acute pain. Um, the big thing, remember, blood's an irritant. As long as it's in your blood vessels, you don't feel it. But if it starts to get loose anywhere in the body, it's going to start to burn. It's going to hurt. Your patient's going to complain of some severe pain. Pain will spread as the blood or contaminant seeks out new voids in the peritoneal cavity. Wherever it goes, the pain's going to follow. So if they're bleeding in their cavity, in their abdominal cavity, typically whatever gravity pulls the blood to, that's where the pain's going to be. So if your patient is sitting up, they're going to complain about pain mostly in their lower quadrants. It makes sense that way. Um, let's see where we're at. All right. A lot of times, a jarring motion will alert the patient to the peritonitis or the inflammation of the peritoneum. So when I talked about hitting somebody in the bottom of the foot earlier, if they have peritonitis or an inflammation down there, they're going to feel it. That's going to be a referred pain. That is just because your hit on their foot traveled up their leg and it caused that pain. If they don't have an inflammation or any problems there, a lot of times they won't feel that in their stomach. They'll feel it where you hit them, but that's as far as it goes. Determining the location of the pain or the referred pain can be difficult, um, especially if the patient is guarding. So we're talking about abdominal regions tonight. If you take a bad hit in your abdomen, just like how like if you break ribs, we talked about guarding where your arms kind of come up and cross in as additional protection. It's the same thing for your stomach. If you get hit in the abdomen and certain organs get damaged or you start bleeding into your cavity when it hurts, especially from an injury, our um, our natural reaction is to guard. We pull our arms in and kind of protect our stomach so that if we're at risk of getting hit again, we have a little bit more protection there. Conscious or unintentional stiffening of the muscles can help the patient avoid further pain. They'll clench down. So if they're doing that, when you go to do your pressing down on their four quadrants, if they're tensed up, you're going to feel that, and it might be distracting. It might kind of come across as them being distended, which is not the case. So just be aware of that. Just look at your patient. If they look like they're gritting down and bearing down and in pain, that could be why you're not getting a good soft abdomen. It could be because they're just all tensed up. But if they look like they're not trying to tense up everything, if they're not in that guarding position, and you press down and you still feel that rigidity, then yeah, it's probably because they have blood in there or something of that sort. A real quick blurb about seatbelts. I'm not going to read this slide to you guys. The big thing I want you to know is that they can cause a lot of superficial injuries, and if the injury is bad enough, they can cause some damage to your organs. But um, despite the damage that a seatbelt can cause, if you were to be in that same accident without the seatbelt, it would be much worse. So keep that in mind. Yes, seatbelts can cause injuries. So can airbags. But if you don't have them, the injuries could be much worse. I try not to get on a soapbox about that because I was bad about it myself. I would always, for a long time, I'd be like, I don't want to buckle up. The seatbelts can cause injuries. Um, but the seatbelt is what keeps you in your seat when you have an accident. So all those other safety features that your vehicle has, they don't mean anything if you get thrown out of your seat. The whole point of a seatbelt is not to stop you from, the seatbelt doesn't prevent you from getting an injury. The seatbelt holds you in place so that the airbags will work right. Oop, went the wrong way. All right, for open abdominal injuries, injuries in which a foreign object enters the abdomen and goes through the skin. So now you've got an open injury to the outside. That's what these are. These are called penetrating injuries, just like they are anywhere else in the body. So we're going to treat them the same. Stab wounds, low velocity wounds, we are only really concerned about what that object was able to reach. Gunshot wounds, high caliber rifles, that kind of thing. If anybody's been shot, then we have to worry about collateral damage inside the body as a bullet was passing through. Did it hit a bone and ricochet? Then you've got even more stuff. And we don't know that. We can't figure that out in the field. Um, That takes x-rays and CT scans at the hospital. So if that's what we're dealing with, make your best guess, make a clinical judgment based on how's your patient looking, how are they acting, that kind of thing. Um, but don't get bent around the axle trying to decide exactly what organs got hit. Ultimately, we want to hurry up. We just want to stabilize them and get them to the hospital. And when it comes to trauma, the longer it takes to get them to the hospital, the harder it is for us to stabilize them. They're going to continue to get worse and worse. So um, time is not typically on your side in these kind of injuries, whether they're open or closed wounds. So your damage depends on the velocity of the objects. Like I was saying, if it's low velocity, it's going to only be in that area. If it's medium or high, then you're looking at much more collateral damage. For eviscerations, this is where they got cut in some way, and we've talked about this before as well. So I'm not. That's why I'm going a little quick here. If I need to slow down, y'all please let me know. I just don't want to. I don't want to torture you through something you've already learned. But in eviscerations, this is where your bowels kind of protrude out from the peritoneum. Um, be it usually it's an intestine. A lot of times your organs like your appendix and stuff are not gonna they're not gonna fall out unless you got like severely almost cut in half kind of thing. Usually it winds up just being a little bit of your intestines that come out. So if this happens, this is extremely painful. It's visually terrifying to say the least. Um, if this is what you're dealing with, don't push down on their abdomen. You might wind up pushing more out. We don't try to put back in what's already out. We just get a large bandage, we wet it, put it on them, and we keep it as warm as we can because we're worried about body temperature there for their organs, but we're also worried about keeping them moist. So warm, wet dressing, get them to a hospital. Um, don't try to put anything back in once it's out. If you need to, you can cut their clothing. We should technically be making our patients what we call trauma naked anyway, so you can see their injuries. But if you have to cut the clothing rather than just take it off, then do that. Most of the time, that's how we operate by default. You'll find most EMTs just carry a pair of trauma shears in their pockets. That way they can do so. If the clothing is actually stuck to the wound, don't pull on it. Don't pull the clothing because it could drag the wound with it or drag the organs with it. Some signs and symptoms for open injuries, you have patients with extreme pain because it's not just their organs that got hit or anything like that. They also have the actual laceration or the hole in their skin and muscle, which is going to be causing a lot more pain than a blunt injury would as well. Not saying that blunt injuries aren't painful. Common sign, actually, they should be a common symptom with what this is saying. Common symptom is going to be tachycardia because when their pain gets really bad, their blood, their pulse and everything starts to pick back up. Later signs will include evidence of shock, such as decreased blood pressure and pale, cool, moist, clammy skin. Their mental status will change. The abdomen will become distended, especially if they're losing blood. A patient may have both closed and open injuries. So if they got hit by something, we'll say something large, all right, like a steel I-beam or something like that, they could get the crushing injury, or not the crushing, I'm sorry, they could get the blunt force injury just from the size of the object. But depending on how they got hit, if they got hit on a corner, the corner could cause an open injury as well. So you're going to have to kind of keep both things in mind. You're dealing with that open injury, but you're also worried about the damage around it that could have happened from whatever it was that struck them. So that's going to fall into your mechanism of injury that we'll talk about later on. That's what you're going to glean from that when you do your assessment. So real quick review on what we talked about tonight. Which organ is going to bleed the most, solid or hollow? Solid. Good.
It's gonna be hollow. Be a solid one.
Yep. Solids. All right. So that being said, if you start to see bleeding through the skin, that means they have a lot of blood loss. If that's what you're seeing, chances are it's not going to be a hollow organ because they typically don't lose that much blood. So think about where everything is located. If you're looking at your patient's abdomen and you see bruising in the right upper quadrant, it's probably going to be the liver because the liver sits up there. If you have bruises in the left upper quadrant, it may be your spleen. Bruises to the flank could suggest injuries to the kidney because remember they're upper quadrant, but they sit real deep. They're closer to your spinal column than they are to your front. So if they were to be bleeding, you're going to see the blood pooling around your backside, maybe around the sides and kind of under your arms a little bit. So depending on where you're seeing the bruising can tell you what organ is probably ruptured. And if you're seeing it through the skin and it's a large bruise, um, it's safe to say that they're bleeding from the organ to have that much blood in that area. If there's bruises around the umbilicus, around the belly button itself, that's actually got its own name. We call it Cullen's sign, and it's predicted. It's a lot of times that is bleeding from your small intestines, that kind of thing. Those usually happen in car wrecks and frontal injuries that hit your patient dead on in that area. Seatbelts can cause it. Airbags can cause it if they're an unrestrained driver and they're in the process of going up and over, like they're going to go toward the steering wheel, and then they get caught by the airbag. That can cause it. So again, just know your mechanism of injuries when it comes to that. All right. Both blunt and penetrating trauma can cause hollow organ injuries. Blunt trauma being, we talked about blast injuries, for example. If you get hit by something hard enough, it can cause your hollow organs to break as well. And if that happens, it's essentially like a balloon popping. Penetrating trauma can cause direct injuries, such as lacerations and punctures. So, a blunt trauma may break a hollow organ without actually hitting it. It's just that pressure, that slap causes it to do it. But penetrating trauma will it'll directly cut it. The gallbladder and the urinary bladder are hollow organs whose contents are potentially irritating and damaging if ruptured. So if your urine gets loose into your abdominal cavity, that's a bad thing. And because it's an acid, it's going to really hurt. That is something else that may get loose in your lower quadrant. If it doesn't look like they're bleeding, or it doesn't look like they would have had damage to a solid organ. You don't see any real signs of major blood loss, but they're still complaining of bad pain down there. Then it could probably be their urinary bladder got hit, especially if you're dealing with patients that were caught in a blast injury or a crushing injury, or a bad enough seatbelt injury could do it, that kind of thing. Especially if they're like bouncing around in the seat because they got to go to the bathroom and then they slam into something. The seatbelt could cause their bladder to pop, and then all that urine is going to go out into their abdominal cavity. Even just air in the peritoneal cavity can cause pain. Usually indicates that a hollow organ or a loop of bowel is perforated because those do have air in them. If it's not rapidly identified and repaired, severe infection and septic shock can develop. For your solid organs, um, we already talked about the fact that they can be heavy bleeding, so we won't beat that to death any more than it already has. Depending on where they get hurt, um, the blood loss, even though it's going to be excessive, it may not be fast, right? Um, so it may not be like an arterial bleed where it's just hard and heavy, thankfully, because we can't really stop those bleeds. If that were the case, then we'd lose most of our patients that had these injuries. It's just that there's so many blood vessels there, and most of them are really down to the capillary level. It's going to be a slow ooze, like it says on the slide. The blood's going to come out slowly, but it's a lot of capillaries. So even though it's not just flooding out, it's going to almost be the same because it's coming from so many different vessels. That would be the problem, and those are hard to fix because if a surgeon goes in and tries to fix, um, that, they got thousands of blood vessels to try to deal with. Usually, it's going to be taken care of by medication or some kind of injection that stops the blood flow there. It's really the best they can do. There's just way too many vessels, and they're way too small to try to go in and surgically reattach anything and of that sort. The liver is your largest organ in the abdomen. This is very vascular and can contribute to hypoperfusion if injured, not just by trauma. In fact, I will say that it would probably benefit y'all if you go to paramedic, you're going to get it in their curriculum. But there's a lot of stuff about the liver that we don't teach you in basic class. And I could probably create a whole other class just for it, so I'm not going to try to teach it all to you in this class. But just as you further your education through your career, learn more about what the liver does. Learn about what it can do if it gets injured. Learn what alcoholism will do to it. Learn what hepatitis will do to it. Because when you look at when you get patients with those conditions, it changes some of your signs and symptoms. It changes some of your treatments. Um, there's actually an extra medication that a paramedic will give if a patient is an alcoholic versus if they're not an alcoholic. Cirrhosis does weird things to the body because it starts to tear the liver apart. Um, that's something that if you guys, like I said, if you, especially when you start getting more into medical as your career goes on, learning what that organ does and what happens when it messes up will it'll just make you that much better of an EMT. Anyway, this is often injured by a fractured lower right rib or a penetrating trauma. The rib cage protects a lot of it, so as long as your ribs are intact, unless you got hit from below and then in an upward movement, your liver is pretty protected. But it can get hurt, especially if it's traumatic, or I'm sorry, if it's a penetrating injury. The spleen and pancreas are also very vascular, so if they get struck, they're going to bleed a lot. Both are prone to heavy bleeding. The spleen is most often injured from motor vehicle collisions, especially in cases of a badly placed seatbelt. Steering wheel trauma can do this. Falls from height onto sharp objects can do this. Bicycles and motorcycle accidents where the patient hits the handlebars on impact, because again, now you're talking about something that would be going up kind of into your ribs from underneath. So that runs the risk of damaging your liver, your pancreas, all that stuff. If your diaphragm is ruptured, loops of bowels may herniate into the thoracic cavity. And the big problem there is it's going to be hard for your patient to breathe, right? Herniation is where any organ goes through a hole that it doesn't need to go through. So a brain herniation, like we talked about the other night, it's where the brain gets pushed through the foramen magnum in the skull and down into the cervical area. A hernia in this case is where your abdominal organs, your stomach, any of that stuff gets shoved up through your diaphragm. And once those things get introduced into your thoracic cavity, it makes it hard for you to breathe because your diaphragm is not going to move as easy. It's being held up. It can't contract right, causes pain. And the stuff that is actually above the diaphragm now is going to take up space so that your heart can't beat as well, your lungs can't expand as well as they should be. And the only thing to fix that is a surgeon. So we have to get them to the hospital as quick as we can. But it's good that you guys would know this and recognize it. That way you're not sitting there going, well, I don't see any blood. You're probably just breathing weird because you're in pain. So nothing I can do, that kind of thing. The kidneys can also be impacted or penetrated by trauma. Um, Again, these are typically protected. They sit up higher than most of us give them credit for. Before I knew better, I always thought they were lower in the back, like kind of close to my hips, but they're actually pretty high up. For as small as they are, they can drop a lot of blood because this is whenever your body's trying to get rid of potassium or anything like that out of the bloodstream, they pass through the kidneys. Your kidneys have to be very vascular to handle the amount of blood that goes through them just for them to do their job. If you do injure these, it's not uncommon for you to find blood in the urine, where the kidneys have just been bleeding into the tube that feeds the ureters that feed the bladder. So the blood's going to be there when they go to urinate. Blood's visible on inspection of the urinary meatus, indicates significant trauma to the genito-urinary system. If you see blood coming out of their in their urine or whatever, that means the injury is far enough down that the kidneys didn't filter it. So it's either coming from the kidneys or it's coming from somewhere past the kidneys. All right, for your patient assessment, we do this just like we have on all the other patients, so a lot of this is going to be the same. But assessment of abdominal injuries is a little bit different because you're covering a wide area, right? And you're not just worried about injuries that you can see. You're also worried about the organs that are below. So causes of injury may be apparent, but resulting tissue damage may not be so apparent. It just depends on what's going on underneath the skin. Your patient may be overwhelmed by other more painful injuries. There's been times where a patient has broken their femur, for example, and they're in such excruciating pain from that bone break that they don't realize how much they're hurting in other areas because that's the overriding pain. Another example would be a patient who is in a traumatic car accident, ruptures their appendix. The extreme pain that comes from that means that they don't notice that they hurt a kidney. They can't tell, they can't feel that flank pain because they're too focused on the pain on the appendix. So it's really important when you're doing your assessment. Remember, I told you guys when you check your 4 quadrants, check the one that hurts the most, check that one last. Because if you make it worse, they're not going to feel anything else, and you're going to miss some things that could be important um, for the hospital to know. Scene size up is going to be the standard as always. So BSI, scene safety. Make sure that you're safe. Make sure that your patient is safe. If it's traumatic, especially trauma in general, but in light of this chapter and what we're going to be getting into, make sure that if there is violence involved, that the assailant is not still there. Um, think about your additional resources. Like it says on this slide, if you need PD, get PD. If you even think you need PD, get them. And in fact, like if it comes across as a sexual assault, it doesn't matter. It doesn't matter. Get the cops out there. And in fact, if they're not already there waiting on you, I would be shocked. Consider your MOI, and consider all the injuries that could be caused by this. So when you're talking about a car wreck, for example, remember you're not just worried about the car versus the tree. You're worried about, did the airbag deploy? Because that's going to cause damage. Did the airbag not deploy? Because that could cause even more damage. The seatbelt, were they strapped in? Do they have injuries from that? Were they not strapped in? Did they bounce around side to side inside the car? All that stuff. Did something penetrate them? Um, and if so, what was it? Can you not really take a guess, which is what I was going to say, but can you see signs that say whether it was a low velocity or a high velocity impact? So what's the extent of the damage? As far as trauma goes, this is the worst area of the body to deal with because it flies in the face of the whole. Trauma is easy because you can see it. This is there's so many things that can go wrong. You're almost treating it like a medical call because a lot of times you can't see the extent of the damage. For your primary assessment, just like the rest, you're going to start off with a rapid scan. So a quick head to toe. This is not your head to toe assessment. This is, you're just, first of all, does your patient look like they're turning green from toxins? Do they look like they're bleeding out or bleeding in, right? Because we have to worry about internal bleeding as well. Um, do they look like they're going into shock? That's the kind of rapid scan you're doing. You just step back and look at your patient. You're going to form your general impression from this. Basically, are they sick or not sick? How important is it that they get to the hospital fast? Do you need to call a helicopter? Do you have time to go by ambulance? If you're not on an ambulance, if you guys go to work for a fire department, a lot of times you may be the first one on scene and you have to make the decision of, who am I calling? Am I going to radio out for the helicopter or am I just going to wait for the ambulance? Address any hemorrhaging first. I am really glad to see that they put that into this curriculum. So instead of it being A, B, C, and hemorrhaging being in C, they took hemorrhaging and said, even though it's A, B, C, put the hemorrhaging first. If they're not bleeding out in front of you, then great, you can go into airway and breathing. If you need a tourniquet for something, put the tourniquet on first and then do A, B, C. For your airway and breathing, um, your normal decision-making process will play through. So first of all, you need to clear the airway, make sure that they have a route for the air to go from their mouth and nose to their lungs. Suction if you need to. Open the airway if they're unconscious. If they'll take an OPA, great. If not, give them an NPA. If they're up and talking to you, then this part's pretty self-explanatory. It's done. When you go to your ride-alongs, you're going to see that your paramedic walks into the room, introduces himself, and a lot of times when the patient responds and the paramedic goes straight to, all right, so what's going on today? And it's because in his head, he's done all of this. You walk up to your patient, you introduce yourself and extend your hand. If they tell you their name and they reach out and shake your hand, you pretty much knocked all of your primary assessment out just like that. But I don't want you guys to do that in class because I still need to see you hit every step. Um, that's going to be one of those differences between real world and class. So in class, I want you to be like, all right, his airway, is it open or what's blocking it? And then I'll tell you. And then you say, all right, I'm either going to suction it or I'm going to put an OPA in and that kind of thing. Once you get through with their airway, then we move on to breathing. Breathing, you have a couple of questions. The first question is are they doing it well enough on their own, right? If they're breathing well enough on their own, they're in that 12 to 20 range or close to it, and they're adequate breaths, then great. You can move straight to, I'm going to give them some oxygen either by a non-rebreather or a cannula. If they're not breathing well, then I'm going to give them oxygen by a back valve mask because I need to make sure that I'm ventilating them properly. If they're not doing it well enough on their own, then I'm going to do it for them. So that determines how you're going to give them their oxygen. But essentially, you're just looking at it as like, are they doing well enough on their own? For your circulation, don't worry so much about the small bleeds, but be aware if the small, if it, if it's not just a superficial cut, like a paper cut, um, the damage may be very minimal on the outside, but it could be massive on the inside. So just because you see a little bit of blood, don't be like, it's just a drop, and then don't go from there. Try to figure out real quick, and you don't have to be a scientist with it, but what caused that little bit of bleeding? Was it blunt force trauma? Because if so, then the bleeding on the inside is probably much worse than what you're actually seeing. Evaluate their pulse, skin color, and temperature. And if they're going into shock, try to determine what stage they're in. Remember, you have compensated, decompensated. If their vital signs are a little high, you're still in the compensated stage and you're going to treat for that, which is lay them down, cover them up to keep them warm, and loosen restrictive clothing. If their vital signs are already starting to trend downward, then you're much further along. You're still going to do the same thing, but you're going to do it much faster, much higher pucker factor because once they go down that road, you can't get them back. So treat it aggressively, get them to a hospital. If you look at a patient, I tell you he's got signs of shock where he's getting cool and clammy, and that kind of thing, you should be like, all right, we going to the hospital like yesterday. And you do only what you have to do on the scene, which is a quick head to toe to make sure you know how to move them, get them on board in the truck, and go. And then you can do everything else, your vitals, your history, your secondary, your whole secondary assessment, your ongoing, all that stuff can be done in the truck. Make your transport decision. Again, in class, they're always going to be a high priority for transport. In the real world, not necessarily the case. For your history taking, clarify your chief complaint and your mechanism of injury. Ask them what it is that they're hurting from, and compare that to what you see, right? Because again, this is much more. Even though it's trauma, it's almost a medical call from a traumatic standpoint because you can't see what's going on inside of them. If they tell you that their biggest complaint is their ankle, but you look at them and they've got massive injuries to their abdominal area or their pee and blood or something like that, well, the ankle is probably not the biggest problem. That just might be the most painful problem. So you're going to want to adjust your treatments accordingly to include those extra things. Get your sample history. As long as they're awake, you can use OPQRST to get more information about the pain. Just remember, the only person that can answer the OPQRST question is the patient themselves. You can get sample from a family member or a friend or even just a bystander who happened to be standing there at the time. But all of the OPQRST questions have to do with the pain. Only the patient can answer that. So if they're not awake to answer it, then toss that acronym out. You're not going to get any of those answers. Ask if there's nausea or vomiting or diarrhea. Um, ask if and make note of any pertinent negatives. Remember, like for example, nausea and vomiting always go together, right? What if they don't? They tell you that they've been throwing up, but they don't feel nauseous. That's a pertinent negative. So make sure you document that. That's important. That actually steers the treatment down different roads because it means different things. And ask about the appearance of any bowel movements and urinary output. So is there blood in it? Remember, if they're peeing blood, that's a problem at either at or past the kidneys. If they're passing blood in their stool, then that's going to be a problem somewhere in their digestive tract, either in the intestines or the stomach or whatever. And then ask them what it looked like. You don't have to be the one to look at their stool, but just ask them, was your blood bright red or did it look like burnt up coffee? Um, the brighter the red is, the closer to the rectum that the injury is. If it looks like coffee, it's because they've digested that blood in the process, which means that the injury is a little bit further up toward the stomach.
Also, could be a GI bleed.
Yeah, it would be. The only thing, usually, if it's an esophageal bleed, they're not going to have that in their stool unless they've been swallowing it down. But then that causes a lot of times your patient will vomit if they're drinking blood. So it usually winds up coming back up the esophagus rather than getting digested. But yeah, it could be.
Yes.
It could be really high. It could be a stomach ulcer. So the bleeding is coming from the stomach and getting passed through the intestines. We don't know. There's no way for us to tell. If that's what you're thinking, you can ask your patient how their stomach feels. Have they been having a lot of heartburn lately and real bad indigestion that's not explained by bad Mexican food or something like that? Um, that would give you the idea that they might have an ulcer, which would be good for your report. But there's nothing that we would do treatment wise for that. So if you get it, great, but don't waste time trying to narrow that down because it doesn't really change anything that you're doing. That's just information to give to the hospital. All right, for your secondary assessment, you may not have time to perform this one at a detailed, comprehensive level. That's okay. If they're really bad off, just do the head to toe, the real quick head to toe, and get what you can. You may wind up spending most of your time doing interventions. Um, for your physical exam, remove or loosen clothing to expose injured areas of the body. Again, we talk about trauma naked. A second. I'm going to hit the mute button. Okay. All right. Remember, like I said, when we're dealing with trauma patients, we want to get them trauma naked. I don't mean strip them down and have them where everybody can see. But when you're doing your check of their upper body, remove their shirt, cut it off, whatever. You can throw a sheet over them for dignity, and then just move it as you need to. Provide for their privacy, maintain their dignity at all times. If you're in a public place, get them to your ambulance and do it there. If it's somewhere where a sheet will suffice, then just throw a sheet over them and treat it like somebody giving you a massage. They move the sheet out of the way, do what they need to do with that leg, cover it back up. Move the sheet out of the way somewhere else, do what they need to do, cover it back up, and do the same thing. That way, they're never actually laying there naked, but you can see everything that you need to see. Your patient should always remain in a position of comfort, whatever is the easiest for them to breathe and the least amount of pain that you can get them in. Because if they're sitting there in excruciating pain, it's going to jack up their heart rate and their breathing, which is going to mess other things up. And then make sure you examine the entire abdomen. Again, if they're complaining about pain in a certain quadrant, save that quadrant for last, but you still want to hit all four quadrants. Don't just go for the pain and then move on. Use your DCAT BTLS as best you can. Remember what that stands for. Okay, I want you guys to be able to rattle it off in one breath when you go to boot camp. Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. It's all the stuff that you would see. And if you're actually looking at a patient, it's easy. because it's going to be like, oh, that's not normal, right? But for class, I need you to tell us what you're looking for. So know what DCAT BTLS is and know when you would use it and when you wouldn't. We don't use it in the primary. All right. Look for the presence of contusions and abrasions because that can kind of tip you off to whether or not they have internal bleeding from an organ. Note the presence of any burns. It could be burnt now. All right. From a trauma, if anybody's never actually been in a accident with airbag deployment, your patients will probably have some mild burns from the airbag. Mostly it's going to be around their arms, could be on their face, just the object, the parts of them that come in direct contact with the bag. They're going to have some scrapes, some possible burns, whatever. That's not what this is referring to. When it says look for the presence of burns, they're talking about pretty massive burns, right? Chemical burns, could be thermal burns, just depends, but not the little scrapes and burns you get from the airbags. That's something you just note and be like, well, that happened from the airbag, and it's pretty safe to say that that's what caused it, especially if there was airbag deployment, and let it go. Usually those burns are going to be really, really superficial anyway, so a lot of times you may not even notice them because you're looking for the bigger things. Palpate the abdomen when you examine that area. Do it in those quadrants. Like I said, save the worst one for the last. This will allow you to investigate the possibility of radiation and extension of the pain into other quadrants. So if they tell you that the right lower quadrant's hurting, press on the other one first, on say like the left lower or the right upper. And if they're hurting there, that will tell you, hey, okay, this pain is deferred, it is kind of spreading out or diffuse or whatever. Um, if they tell you that they're hurting in the right lower quadrant, and you press on the left lower and the right upper, and it does nothing for them, they don't feel any pain. They're like, it's whatever, it's just hurting here. Then it lets you know that too. Perform a full body scan to identify injuries other than your abdominal injuries. Don't get that tunnel vision, especially if you're dealing with something like a blunt force trauma or a crushing injury, something that is widespread. Um, the injuries could be beyond just the abdomen, but you're going to be, in the grand scheme of things, you're going to be doing a head to toe anyway, so you'll get it. Um, Begin with the head, finish all the way down to the toes, or at least if you're in your first run and you're just trying to make sure you can move them to the ambulance. If you get to the knees and you haven't found anything wrong with the legs, you can stop there. If you get to the knees and there's something like a deformity or something wrong with their skin or whatever, then go ahead and check a pulse in their foot, make sure that it's there, just so that you know, and then move on. Once you've made it to the toe, roll them over, check their posterior. When it comes to these kind of injuries, when you check their posterior, you're not just running your fingers down their back looking for injuries. I want you to actually check their rectum. You don't have to, I was going to say you don't have to get them naked, but if you can, it gives you a better view. You want to make sure they're not bleeding from the rectum, because if they hurt their intestines, an abdominal injury to the intestines could cause the blood to escape through the rectum, and that will be your telltale sign that they've done some kind of massive trauma to their lower intestines. Assess for the need for spinal immobilization, depending on how bad they got hit. Even if they got hit in the hips, for example, the force of the impact could have whipped their head to the point where they need a spinal immobilization. And if they got hit there to the point where you think they might have a damage to their spine, this would be the time where you would probably give them a longboard. I know we keep harping about not using it all the time, but this would be the time where you would want to grab a longboard, because it's going to be lower back injury, could be damage to the hips, damage to the legs, all that stuff. That's where the longboard would come in. If it's just I was in a car accident and I think I hurt my neck, they don't need a longboard. Inspect and palpate the kidney area for tenderness. So again, remember those are your upper quadrants, but they actually sit posterior to everything else. So if you're going to be palpating for that, that's not going to be palpated in your four quadrants. That's going to be palpated along the back side. You can palpate in the upper quadrants, but you're gonna have to push hard to find out if their kidneys are hurting. And I mean, God forbid if they got another injury in their upper quadrants, you're gonna basically be they're gonna think you're trying to kill them to palpate their kidneys. So check those areas from the actual flanks and along the backside. It's easier for your patient, especially if they got hit in that area. Get your vitals. Pay close attention to your numbers. Again, when we go to the boot camps, I'm going to teach you guys, I'm going to do an actual vital signs class for you guys, probably one of the days right after lunch when everybody's food is settling before we start doing hands on again. We'll do a little, everybody sit down, vital signs class. Don't fall asleep on me. That's all I ask. And then we'll continue our day from there. Use appropriate monitoring devices. If the MOI suggests an isolated injury to the abdomen, you can focus on that injury only, but that's if it's a mild injury and that's all you're concerned about. If they have an altered level of consciousness, they're getting a head to toe. If they're unconscious and like fully unconscious, they're definitely getting a head to toe because you don't know. They're not awake to tell you. And then your reassessment. Um, the big thing there, again, as always, is if they're critical, every 5 minutes. Um, if they're stable in the real world, because it won't be stable in class, but if they're stable in the real world, 15 minutes is fine. And those are guidelines. If your patient does look like walking death at the moment, you may not want to wait 5 minutes to recheck your vitals. You get everything done. You're sitting here like, well, what do I do now? I got 2 more minutes till my next recheck. Just go ahead and do it. It won't hurt. Make sure you do good documentation. Whenever you document pain, make sure you document where it's at. Document how your patient described it, not necessarily just your objective statements. Put in the subjective stuff as well. Like, all right, they said that the pain was a tearing sensation. They said it was in this quadrant. And if it doesn't make sense to you, like if what they're saying, for example, a tearing pain, um, if they tell you that something feels like they're being ripped apart, but then they start throwing in things that look at other organs away from their aorta, it could be that they're faking. We don't know, right? It could be that they have multi-system trauma. All these things, put it in the report. All right, it is 7 o'clock. We're going to take a break, and then we're going to pick up with emergency care for the different types of injuries and go on from there. So be back at 7:10, and we'll continue where we left off. All right, let's get back to it. So we're going to talk about different kind of injuries that you may deal with for the abdomen. We start off with closed abdominal injuries. Your biggest concern about closed injuries is that you don't have a way of knowing exactly how bad the injury really is. Um, Most of what we can see is just damage to the skin, possibly damage to the muscle, and even if you do see some internal bleeding or bruising, rather, um, it doesn't necessarily mean that they have that bad of an injury. It just depends. But because we can't see, because we can't test, we have to err on the side of caution and take the worst possible scenario. I'd much rather you guys overtreat and be overly concerned than to not be concerned enough and have your patient sustain more injuries because we didn't do certain things to try to help them out. Remember, um, you have the injury. I want you to think about it kind of like how when we talked about your brain injuries, you have the actual injury and then you have your secondary injuries on top of that. So, same thing with a lot of the organs in the abdomen. If they're losing access to blood because they're bleeding out in the abdomen and we fail to give them proper oxygen or we fail to give them some other intervention, now they have the injury plus it's exacerbated because they're hypoxic or whatever other issue is going on out there. For patients that do have legitimate injuries, the patient requires rapid transport to the nearest and highest level of care, primarily to a trauma center. The only thing that can fix this is trauma. If they're stable enough for you, for example, if you're in Poplarville, and not everybody here knows where Poplarville is at, but imagine you're in a small town and you have a small hospital that's got a doctor, a few nurses, a couple of techs, and they can help you stabilize your patient. And then 45 minutes past them, you have a level 2 trauma center with the capability of fixing your patient. If they're stable enough for you to get to the trauma center, go to the trauma center. If you can't stabilize them with what you've got in the truck and you're worried they'll be dead by the time you get there if you don't make the stop, then make the stop at that smaller hospital. Use their extra resources, use their extra higher levels of care, the nurse, the doc, all that stuff. Yeah, they're not going to fix it. They still have to transfer the patient, but you're worried about stabilization at this point. So let that be your deciding factor. Be like, all right, my patient is pretty much dead, and if or my patient is stable enough that I can make it 45 minutes up the road, then make it 45 minutes up the road. That kind of thing. Positioning the patient for comfort because the more comfortable they are, the more their vital signs are going to want to behave. Apply high flow oxygen, especially if they're showing signs of hypoxemia or a shock, and then definitely treat for shock. And you should be looking at shock in your primary assessment. So when you're doing your ABCs, somewhere in there, preferably after C, treat for shock. A patient with blunt abdominal wounds may have severe bruising of the abdominal wall and in different locations, possibly different organs. Liver and spleen lacerations. A lot of times that's where the blood's coming from. Rupture of the intestine, tears in the mesentery, which is where, again, that's where your intestines actually attached to the abdominal wall. That's their blood supply. So if they rip off of that, all those blood vessels are going to be just bleeding into the abdomen. Rupture of the kidneys or avulsion of the kidneys from their arteries and veins. Your kidneys are kind of like your heart. They hang. They hang from their veins. Or rather, I'm sorry, they hang, but not the veins aren't supporting the weight, but there's no extra slack. So if the kidneys if they rip off of the tendons and the things that hold them in place, if they come loose of that, they have a really high risk of shearing off of their blood vessels as well. So they have a high risk of bleeding that way. Rupture of your urinary bladder, severe intra-abdominal hemorrhage, and peritoneal irritation and inflammation, particularly from either the blood or other bodily fluids that are getting loose in the abdomen. A patient with a blunt abdominal injury should be log rolled to a supine position on a backboard. Um, this is one of those times where you can use it if you're using a backboard because of abdominal injuries to organs, then you could technically remove the board if you needed to. If that, just watch your patient. If they look like they're having a hard time breathing, take them off the board. The times that you put a board on somebody as an intervention that only the doc can remove them from is if you're trying to use it as an intervention for a spinal injury. So If you think your patient needs it because they hurt their lower back or they've hurt their spine or something like that, then when you use that board, the doctor has to take them off of it. But if you're using the board to help it to make it easier to move your patient, for example, then the board is not an intervention, it's just a tool, and you can move it at that point. Protect the spine, monitor the patient's vital signs for any indication of shock, and treat appropriately. When you're dealing with open abdominal injuries, generally these wounds are obvious. The external bleeding, however, is usually coming from the abdominal wall, that kind of thing. It's not necessarily from the organs, unless whatever injury caused that open injury managed to hit those organs. You could have massive bleeding. If you are dealing with that with an open injury, though, the saving grace for you as an EMT is you typically see the blood. It's coming out pretty profusely. You know they're having a bad bleed. Whereas an internal bleed, you don't always see it until they've already lost all that blood, and now you're way behind the curve. Maintain a high index of suspicion for serious unseen blood. Just because it's not coming out of them doesn't mean it's not coming out of their vessels. You may still only be seeing the tip of the iceberg as opposed to what is actually pooling inside of them and not coming out of that injury. Only a surgeon can accurately assess the damage, so always prepare for the worst. Get them to the hospital as quick as you can. Inspect the patient's back and sides for an exit wound if they've been shot. If it's a knife wound, probably not going to have an exit wound unless they got stabbed with a sword. Apply a dry, sterile dressing to all open wounds. And if the penetrating object is still in place, we stabilize it. We don't remove it, right? It's just like any other impaled object. If they got stabbed with a knife or ice pick or even something accidental, say a piece of rebar came loose off a truck and ran through them, we don't remove it. You may have the fire department cut the excess off so that you can move your patient, but don't remove what's inside of them, because that might, the presence of it, as bad as it is, might be stopping the bleed from being so bad that they die on you from blood loss. Severe lacerations of the abdominal wall may cause an evisceration. Is that this? No, that's not this slide. There we go. There you can see it in the picture. These, like I said, these are hard injuries to deal with because of how bad they look, but the treatment is pretty easy. Take an ab pad, the biggest bandage you've got on the truck, wet it, preferably warm water, but if all you got is regular temperature, then that's all you got. Wet it, put it on them, secure it in place, and especially if it is cold water, take a blanket and cover the bandage so that they can start to preserve some body heat and warm that water up faster, because we don't want them to go into shock just from the cold temperatures. Keep that in mind. And like we talked about before, don't try to push it back in. Keep the organs moist and warm. Cover the area with sterile dressings. We want to try to minimize the amount of infection they may get, even though just by being exposed in general, they're probably going to be fighting sepsis. Secure the dressing with a bandage. Secure that bandage with tape. And if, like I said, if all you had was cold water to wet your bandage with, then wrap your patient to keep your patient warm. Use blankets, use whatever, saran wrap, whatever you got to try to hold in heat. All right. So now we're going to shift gears. We're working our way lower. Now we're going to move into the genito-urinary system. So we're not so much worried about the organs in your quadrants. Now we're below that. Even though some of these organs are in your abdominal cavity within those quadrants. So we're going to be talking about the same areas, just different organs. The genito-urinary system controls reproductive functions and waste discharge. So all of that is what we're going to talk about. Organs include the kidneys, which again, that's all the way up in your upper quadrants. So that's what I was talking about. Your ureters and your bladder and your urethra, they're all hollow organs. So if they rupture or take damage, you're not so worried about the blood loss, but we're very worried about the contents within them. That's all the toxic stuff your body's trying to get rid of. You don't want that just swishing around in your abdominal cavities. The genital system controls your reproductive processes. So the male genitalia lie outside the pelvic cavity, which is a blessing and a curse when it comes to accidents because um, they're physically separated from our abdominal cavity, so we don't have to worry about damage there. But because of that, they're actually more exposed, more likely to get hit. If you've ever taken a kick between the legs as a guy, it's bad enough to make you want to throw up. I mean, you'll feel the effects of that all the way up, but um, we don't really have a lot of protection for that area down there. If we get hit either on a motorcycle accident or a fight with somebody, whatever. The female genitalia are pretty much internal, with the exception of the vagina and the parts that make that up. So their organs, a lot of times, if they're having GI problems, it's going to come across as stomach pain for them because that's where everything is located, or low abdominal pain. Whereas guys, we're going to definitely have some deferred pain up there, but obviously the pain is going to be, we'll know what happened. We'll very well know that that's the problem. Some kidney injuries are going to be what we talk about first. They're not unusual and they rarely occur in isolation. Kidney stones can be an issue if you got hit, if you're in a car accident. These can cause issues with your kidneys. A forceful blow or a penetrating injury is often involved. Less significant injuries can result from an indirect blow or even a football tackle. So a lot of times, football players, high schoolers, they have issues where they get damaged in their kidneys. They may wind up peeing blood from getting tackled too hard or whatever. That's not uncommon. It's just not that bad of a hit. That's something that typically the kidneys recover from. They're fine. They might have popped a couple of blood vessels in there, and so the blood escaped through their urine. But if it's from something that's a high impact, like a car or a significant fall, um, those injuries are obviously much worse. So if they have an abrasion, a laceration, or any kind of contusion to the flank, you can assume that they've got kidney damage. If there's a penetrating wound in the region of the lower rib cage, um, around the flank side, could possibly be kidneys involved. Fractures on either side of the lower rib cage, the ribs can actually do some damage. And then any kind of hematoma in the flank region. If they've got blood, like bruising around their flanks, a lot of times that's a sign that the kidneys are what's causing the bleed. Urinary bladder injuries may result in a rupture, and then now you've got urine spilling into surrounding tissues. Blunt injuries to the lower abdomen or the pelvis can cause rupture to the urinary bladder, particularly when the bladder is full or distended. So the more you're holding it in, obviously, if your patient just went to the bathroom before they had their accident, they're actually less likely to have ruptured their bladder. It's kind of common sense when you think about it, but a lot of people, it's just not something that we consider. So you can ask them if you're worried about that. Say like, when's the last time you went to the bathroom? Did you have to go to the bathroom before this accident, or did you go recently and you're not concerned about a full bladder? That's just an extra question for you to consider. Penetrating wounds of the lower mid abdomen or the perineum can directly involve the bladder. In males, a sudden deceleration from a motor vehicle or a motorcycle crash can shear the bladder from the urethra. In latter trimesters of pregnancy, sometimes just a displacement of the uterus can cause bladder injuries. If some of you ladies that have children, you probably know that as you got further into your pregnancy, going to the bathroom sometimes was a little bit different. You would go from not having to go at all to suddenly nearly peeing yourself. You had to go so bad, and there was no transition to it. Um, yeah, can y'all hear me? I know I'm unmuted. You can hear me, or did you lose audio? Okay. All right. All right. Hold on. Let me type to them real quick. I'm gonna kind of pause for a second while they relog. Maybe it's something with their connection. Oh, you okay? You can hear me. All right, no problem. Yeah, it probably was just your connection slowing down temporarily. All right, getting back to it. So let's see. Okay, next slide. Awesome. All right. External male genitalia injuries. Even though these are outside of our abdominal region, we don't get injured that often there. Usually it's something specific like a motorcycle accident or a bicycle accident. If we fall onto something that we wind up straddling it when we land, that kind of thing. These are soft tissue wounds. They're extremely painful. It's funny that it says they're of great concern for the patient. Um, that's the understatement of the year. But very rarely are they life threatening. Usually it's a mental thing for guys. If we take an injury down there, um, you're almost you're worried about blood loss. You're worried about that kind of thing. But it almost becomes more of a bedside manner thing when you're dealing with a patient that's got these injuries. Um, you want to be supportive of them, reassure them as best you can. Don't give them false hope. If they are mangled up like John Bobbitt or something, then it is what it is. Try to help them as best you can. But if it's something that it may not, like you as an EMT, you may look at it and be like, all right, it's not that bad of an injury. But to your patient, it could be like the end of the world to them because they don't know, especially if they've never been injured down there before. They may think they're going to have to amputate, and suddenly that's going through their head, and what happens then. So this should not be given priority over more severe wounds unless there is significant bleeding. There are a lot of blood vessels there. A lot of how we function is due to blood being able to get into that area. So depending on the injury, it could be a ton of blood loss. That would be something you need to actually focus on that on. Otherwise, don't let that distract you from an airway issue or a breathing, or a circulation issue, that kind of thing. For females, you guys, most of your stuff is internal, so you don't have to worry about it too much. Very rarely do you get damage to your organs like your uterus, your ovaries, and fallopian tubes. Those are pretty well protected. A lot of times, the damage that comes from those is not traumatic, it's actually medical. So, like ectopic pregnancies can cause damage to those. Cysts, ovarian cysts can cause damage to those, but those aren't trauma. At least not trauma like how we define it. Um, so in this particular chapter, though, where you're talking about somebody in a car wreck, um, those organs are usually pretty safe. Exception to this is a pregnant uterus, because your uterus, if you've let's see, okay, I'm still on the right slide. In a non-pregnant female, the uterus actually comes up a little bit on the anterior side, kind of, I would say, below the belt, but maybe for like 4 inches above the vagina. The uterus comes straight up, but then it kind of folds backwards and runs posteriorly, um, over their organs that are there. So normally the uterus is protected, but as a pregnancy happens, that uterus, as the baby grows, the uterus starts to slide it anteriorly toward the stomach, and then obviously it continues because the woman's getting pregnant and her belly's growing that direction. Um, the further into the pregnancy they go, the more that organ, the uterus is susceptible to injury, because now it's not laying off in the inside of their abdominal cavity protected by everything. It's way out front. Um, so that's just the thing to keep in mind. If it's a pregnant lady that was in a car accident, now you really got to start worrying about, did you take damage to the uterus, and then what comes with that, right? If they're bleeding from that organ, is it affecting their child? We're going to talk about OB in the next module, but kind of leading into that from here, if they're pregnant, you're worried about the baby, you're worried about that organ, because that organ is the lifeblood of the child. The uterus um, needs to not be severely damaged during a pregnancy because the child's connected to it basically, and that's where they're getting their blood flow and everything from the mom. Injuries can be more serious because the uterus has a rich blood supply. If they do have a traumatic injury to that in pregnancy, they will lose a ton of blood and you really won't notice. Pregnant women have more blood than non-pregnant women because they need the extra blood supply for the baby. So they'll lose a lot more blood, and then that's dangerous for both mother and child. For external genitalia, basically talking about the vagina and everything to go with that, very rich nerve supply. So I know when I was a kid, I used to think that girls could not feel pain like we do if we got kicked in between the legs, but as an adult and knowing, well, just as an adult, that's not the case. It's very very painful for them as well when they take when there's trauma there, and it could be anything from just a mild trauma to same thing as us. You know, women ride motorcycles too. What happens if they get into a wreck? Um, you have to consider that they're going to be in extreme pain. There is a lot of vasculature down there, so bleeding can get pretty extreme. Consider sexual assault in pregnancy when you're dealing with patients of this type. Ask about their last known menstrual period. You want it's not just about figuring out if they're pregnant or not. When we're dealing with trauma, you may be having to differentiate between menstrual blood and traumatic blood loss. So asking that will help you differentiate that. You don't know necessarily what you're looking at. Ask about sexual history. Assume all women of childbearing age are pregnant until proven otherwise. So they may tell you no, they may swear up and down that they're not pregnant, but as far as your treatments go, just assume that they are. Now, the good thing is as an EMT, it really doesn't change your treatment too much. As a paramedic, that changes what medications you can give. So it's a little bit harder at that level. It's more important, but yeah, if you're treating as a basic, if you're treating a female, just assume that they're pregnant, even if they're not. In cases of external bleeding and trauma, a sterile absorbent sanitary napkin or pad may be applied to the vagina. Don't put it in, just press it up against it so that any blood that comes out will get collected by that. Um, Keep them. They're not attached to your patient, so keep them with the patient so that when you bring them in, the hospital can see how much blood they've lost from that area. They can look at how many pads did you saturate, that kind of thing. Don't insert anything inside of a girl. No instruments, gloved fingers, or a tampon into the vagina. This can cause further damage. There is, when we get to OB, there's an exception to this rule, but hope to God you never have to do it because if you do, you're not getting out of there. Your hand is there until you get to the hospital, and it's not a position anybody really wants to be in, not you or the patient. All right, so moving into your assessment, scene size up. A lot of this is going to be the exact same. You're just thinking about what organs in this area could be damaged. So your size up is going to be the same. We're not even going to really bother going into this. PSI scene safety, use your gloves. Determine your mechanism of injury. If it's something like a motorcycle accident, well, the bike itself would be the mechanism of injury to this area. There's a huge potential for embarrassment with your patient.
I'm sorry.
Hold on. There's a huge potential for embarrassment with your patient, both guys and girls. Right? Nobody really likes to admit that something's going on down there, even something traumatic that is way beyond anybody's control. So maintain your professionalism, maintain their dignity. If you can get them away from prying eyes, do it. The best place to do your assessment is in the back of the truck where nobody can see. Um, of course, obviously, if you're a male assessing a female, have a female present, and if you can, just let the female do it. So it's much better. Provide for privacy when possible. Have an EMT of the same gender perform the assessment. I'm getting ahead of myself. So, for your primary assessment, you do your ABCs. Worry about hemorrhaging first. If the injury is local to the genito-urinary system, a lot of times their airway and breathing is going to be fine, but just don't skirt that responsibility. Make sure that you check it just in case. Because again, multi-system trauma, if it's a bad accident or something like that, you may be assessing the GI because that's the most apparent visible injury, but there may be something that you missed. So make sure that you do your assessment the same every single time. Get it down to muscle memory. Your GI system is very vascular, so it's very easy to have a lot of blood loss. Um, don't avoid the area when you're doing your rapid scan. Life-threatening hemorrhage must be addressed immediately, then move into your airway and your breathing. Control the bleeding if it's seen. Make your transport decision. A lot of times, injuries to this area can be life-altering, but not life-threatening, if that makes sense. We're not so much worried about our patient dying on us from a GI injury, at least not a traumatic one. But unless we're talking about something like the bladder rupturing or the kidneys rupturing, that's a different ballgame. But when you're talking about the genital side of things, it's not so much that your patient's going to die, but if you don't get them to the hospital fast, they may not be able to do any repairs, and then that's going to change how your patient's life and lifestyle continues from there. So even though they may not die on you, you may want to drive fast as if they were, because if they don't get the treatment that they need in time, it's going to cause some major life-altering issues that they can't they can't go back to how they used to be. Investigate your chief complaint. Common associated complaints with GI injuries are going to be nausea and vomiting. Like I said, if you've ever been kicked in the balls, sorry for the bluntness, if it's a bad hit, you'll probably throw up. I know I've been in that situation a couple of times where it's like you get hit, and aside from the pain, you're just trying not to lose your lunch. That is a common sign. Diarrhea can happen, blood in the urine, especially if it's a kidney issue or a bladder issue, something along those lines. Vomiting blood, abnormal bowel and bladder habits can be other signs and symptoms. Get your sample history. Again, your OPQ-RST. Usually your patients, just based on these injuries alone, your patient should usually be alert and able to talk to you. If they're not, then I would be definitely looking for other injuries, because this usually doesn't knock your patient out. Ask the patient about their output. So we're talking about when's the last time they went to the bathroom, either to pee or to pass stool, and then ask if they saw any blood in it. That's an important question. You want to know if they're passing any blood. Get their allergies and medication, or any environmental triggers that may be causing issues. It could be contact injuries, could be contact allergies. You want to get that information. This is one of those issues where the last intake of food and fluid is actually pretty important, because you want to know, what's the likelihood that there's some food or drink that's actually trying to get through their system in these parts. Maybe, did they drink anything that maybe should be collecting in the bladder by this point? Because we can't see if they have a ruptured bladder. And if they drank a lot of water, or if this is something after a night of drinking at the bar and they were in a car accident, they run a high risk of having a ruptured bladder, because they were probably having to go to the bathroom, and they were holding it to get where they were going. For your secondary assessment, um, it's really hard to do an assessment on this. I mean, it's almost awkward just to talk about it in class. But if you're really dealing with a patient that's got genito-urinary issues, um, it's going to be awkward trying to do your assessment, your head to toe with them as well. Big thing, privacy, privacy, professionalism, maintain their dignity. But it's going to be the same assessment as anything else we've done. So decap BTLS, identify the wounds and control the bleeding as best you can. For significant trauma, start with a full body scan to see if there is trauma affecting multiple systems, because you don't want to get that distraction and tunnel vision of, oh my God, this dude's about to have, he's having a bad day, and I'm focusing on this, and I missed the piece of metal sticking out the side of his chest or something of that sort. Presence of penetrating injury indicates possible internal injury to that should be managed accordingly as best as you can. Presence of burns must be noted and managed immediately. Remember, if it's first or second degree burns, we do moist dressings. If it's a third degree burn, we do dry dressings, and we worry about body temperature loss. Anybody remember from the rule of nines what percentage of your body surface area is burned if it's your genitals?
1.
1%. Seems like it should be worth more than that. Look for
Me too, but I didn't make the rules.
Look for lacerations and localized swelling. Depending on the type of injury, a lot of times your mechanism will kind of point you down that road, but just make sure you take a good look for it. Get their vital signs and understand that because of the mental aspect of these kind of injuries, their vital signs are probably going to be sky high if they're awake enough to know what's going on. So tachycardia, tachypnea, weak pulse, because their fight or flight's going to kick in. That's the injuries there they're very, very traumatic on a mental standpoint. So your patient's going to have this freak out. They're going to be, if they're not already freaking out, good for them. But your job is going to be, aside from just controlling the bleeding and stabilizing your patient, is try to keep them calm. Your reassessment doesn't change, right? Reassess any life interventions you had to do. Check to make sure they're not bleeding through their pads or bandages or anything like that, and then add more if necessary. Keep an eye out for shock and make sure you document very well. For emergency care for the GI system, your kidneys damage is kind of hard to spot. So pay attention to what your patient says, like how they're describing their pain is going to be huge. You'll see signs of blood in the urine if the kidneys are damaged. Treat for shock, transport promptly, and monitor their vitals en route to the hospital. For urinary bladder, suspect an injury if you see blood at the urethral opening. So if they're not passing blood in their urine, but they are just bleeding out of the urethral opening, probably going to be damage there and not necessarily the kidneys. If it's coming out in the urine, it's usually coming from the kidneys or the bladder itself. It could be, but a lot of times that is passed with the urine. Signs of trauma to the lower abdomen, pelvis, or perineum. If shock or associated injuries are present, then monitor O2, get them to the hospital. For male genitalia, a few general rules for treatment of injuries to the external male genitalia include injuries, just know that this is painful. There's usually a lot of blood loss, and I guarantee you most of the guys in the class are probably cringing just getting through this because it's painful just to think about it. Use a sterile, moist compress to cover areas stripped of skin if they were avulsed by something. Apply direct pressure with dry, sterile gauze to control the bleeding. Don't try to manipulate any foreign bodies, any objects that may be there. If something's in the urethra, just leave it. All right, we treat it like any other impalement. Try to stabilize it and get them to the hospital. Let the surgeons take care of it. Identify and take any avulsed parts to the hospital with the patient, because if you can get it there fast enough, a lot of times they can reattach everything and hopefully your patient has a good recovery. If they do have an avulsion, treat it like you treat an avulsion of a finger. If it's still attached, then yeah, oh God is right. If it's still attached, try to keep it secure where it's at. If it's completely amputated, then put it in a bag with water. Put that bag in a bag with ice to make it cold, but so that you don't have the direct contact with the ice. Keep it with the patient and get him to the hospital. All right. Amputation of the penile shaft. So, thankfully I haven't dealt with this in my career. I definitely haven't dealt with it personally, but Lorena Bobbitt comes to mind. Back when I was younger, she said that was in the news where she had chopped off her husband's junk, basically. If if you're the EMT responding to something like this, blood loss is going to be your top priority, because a guy can, if this happens, the blood loss from the guy can be life threatening. Like that's that kind of a hemorrhage. Use local pressure with a sterile dressing on the remaining stump. Never apply a constricting device. All right, so this is not something you're going to put a tourniquet or a rubber band or anything of that sort on. It's just pressure. Just use direct pressure to try to stop the bleed. As many bandages as you've got, or as many bandages as you need. Surgical reconstruction is possible if you can locate the amputated part. Treat it just like any other amputation. Wrap it in a moist sterile dressing, put it in the bag, put that bag in a bag of ice, and transport it to the hospital. If the connective tissue surrounding the erectile tissue is severely damaged, then the shaft can be fractured or severely angled. Some people have called this a broken penis, almost like you break a bone. It's not the same because there's no bone actually there, but it's in a sense, it's more like you broke your nose. So I feel bad for y'all. Then I think about having a child. Yeah, but you're designed for that. We're not designed to lose a body part. Anyway, this is, like I said, this is a painful portion to get through. This is probably my least. I think from now on, I'm handing this chapter off to somebody else. I don't want to teach it anymore. Accidental laceration of the head of the penis is associated with heavy bleeding because it's so vascular. It's also associated with extreme pain because it's also very neurovascular as well. Skin of the shaft or the foreskin can get caught in the zipper. Anybody seen something about Mary? We've got a bleeder. That's it can happen. Um, Wear underwear. So this is sadly, it's not an uncommon event. Like this does happen. If a small segment of the zipper is involved, you can try to unzip the pants. If it's a bigger catch, you just leave it. Um, do what you need to stop any blood loss. But if they are really caught in that zipper, then you're gonna do more harm than good trying to get it loose. Just try to get them on the stretcher so they're not trying to walk, and get them to a hospital. If you have to do anything down there, just like with the girl, explain what you're doing. Because the minute you pull out a pair of scissors to a guy that's stuck in a zipper, if he wasn't freaking out before, he's definitely going to be freaking out at that point. So make sure you're communicating very well. Be careful not to injure the scrotum while cutting. Um, if there's, let's see, I'm on the right. There we go. Urethral injuries are also not uncommon. The urethra is actually the tube that runs the length of the penis to let you go to the bathroom. Lacerations can occur from a couple of things. Straddle injuries from motorcycle accidents can cause this, pelvic fractures, penetrating wounds of the perineum. And it doesn't even have to be something external like that. There are people that have injuries to their urethra because they passed a really huge or even just a really sharp kidney stone, which is technically a traumatic injury, even though there was no accident involved. You may show up to somebody that says that they're bleeding out of their penis or whatever, and that there was no accident. It was just, it winds up being that they passed a kidney stone that did some damage on the way. Um, that's always a possibility. It's important to know if the patient can urinate and if there's any blood in the urine. So make sure you ask that in your sample history. Save any urine for later examination at the hospital. That's funny that they put that here. If your patient can hold it, just tell them to hold it. If they need to pee, you can give them they make, I forget what they're called, but they're cups that your patient can pee into with a lid. Keep it with your patient, take it to the hospital so that they can run it through the lab and see what's in it and all that stuff. No, you do not have to fish urine out of the toilet. If they peed before you got there, then that is gone and you don't have to worry about it. And we already talked about avulsions. We pretty much beat that to death. So avulsions and amputations pretty much operate the same. For female genitalia, treat lacerations, abrasions. Yeah, guys, we're done. The guys are done. Your traumatic experience is over for the night. Treat lacerations, abrasions, and avulsions with moist, sterile compresses. Obviously, there's nothing to tourniquet here, so we don't even have to talk about that. Use local pressure to control bleeding. Nothing goes in. All right, if they're bleeding, you just put the pads up against the opening and put pressure there, but don't try to insert anything. Don't pack dressings in there. Don't put your fingers in there. Don't put tampons in there. That's not how we stop the bleeding. Injuries are painful, but generally not life-threatening, just like for males, unless it's an amputation, which for females, y'all don't have that problem. In-hospital evaluation is required, so they're going to go. Even if they don't go with you, they need to go with somebody, be a parent, a spouse, or whatever. Transport urgency is determined by associated injuries, the amount of hemorrhage if they are hemorrhaging, and the presence of shock. If they are going into shock, then they need to go with you. If they're just bleeding but they look fine otherwise, then they don't necessarily have to go with you, but they should still go get checked out. For rectal bleeding, this is a common complaint, and there's a bunch of reasons that this can happen. And not all of them are, some of them you would actually be kind of like, you wouldn't even think that would cause it, but it could just be something they ate, really bad pepper. For example, a buddy of mine has I forget what it's called. It's like one step down from a ghost pepper. And if you, man, like this is not my favorite chapter either. Um, if you eat too much of that pepper, you will probably bleed into the toilet. It's that strong. But bleeding from the rectum may present as blood in or soaking through undergarments. It may be passed into the toilet with a bowel movement. It could be coming from hemorrhoids, sexual assault, rectal foreign bodies. Colitis can do this. Some forms of cancer can do this. Ulcers. Significant rectal bleeding can occur after hemorrhoid surgery. So somebody may have a history of hemorrhoids. They've already gotten. Yeah, that's actually it. The Carolina Reaper. That's the pepper that he's got. Wow. I'm afraid to eat it. I ain't gonna lie. Significant rectal bleeding can occur after hemorrhoid surgery. So if they have a history of hemorrhoids, that's probably why they're bleeding. But don't focus on that, but just know that that's a big cause. It could be that they started sitting down too soon. Any of those things can cause it. It's just another surgery, just like anything else. But it can lead to significant blood loss or shock, especially if they're internal hemorrhoids. If they're external, a lot of the times you're only going to bleed out what is external, and then that's it. So, all right. Last topic of the night. We're taking a bad chapter and we're ending it in the worst possible way, unfortunately. So, sexual assault. All right, this is actually, I mean, you won't hear any jokes out of me anywhere near this. Sexual assault and rape are all too common. I wish that I could say otherwise, but unfortunately, that's the world we live in. Victims are generally women, but they're not exclusive. This can be men and children as well. In fact, as in the military, um, I've actually had a few males have to go to the SARC because of sexual assault. You may respond to prisons where inmates have been assaulted, and just, especially if they're there for something like they were accused of being a pedophile or something of that sort. That's really common. So you may deal with that. Often there is little you can do because the damage has already been done. Most of the damage is going to be mental. I'm not saying it's in their head, but I'm saying that this is a traumatic event, um, and it is very difficult for your patient. And unfortunately, the aftermath with the cops, with the hospital, and everything, it takes a bad situation for them, and it makes it even worse. So the most um, empathetic, caring bedside manner that you can muster. I mean, I don't, whatever we do for joking and stuff outside of it has no place here. Um, that's going to be the biggest thing. That's going to be what your patient remembers, is it through all the shit that they're going through. It's how did you treat them? Don't examine their genitals unless there's obvious bleeding. So if you're looking at them from across the room and it looks like they're bleeding out, then yes, do your assessment. But if it's a sexual assault, then the less you have to touch them, the better. Follow appropriate procedures and protocol. Um, you can't make this privacy enough. There's no, even alone in the back of the ambulance is going to be still hard for your patient. But shield them as best you can from onlookers. Document the patient's history, assessment, treatment, and response to treatment for possible court appearances, because it's very likely that that's where this is going to go. Don't speculate. All right. I know that some people are bad about that. You show up and it may be that your victim was a prostitute, or who knows. But don't jump to conclusions. Don't let that cloud your judgment. Damn sure don't let that cloud or affect how you treat your patient. And be objective only, especially when you get down to your documentation. Don't put any assumptions in there, because again, it's probably going to wind up in court. Follow any crime scene policy of your EMS system, and usually that winds up deferring to how the police want things to be. Treat everything like it's a murder scene. So we don't move anything if we can help it. We don't touch anything if we can help it. We don't. We try not to let, unfortunately, the crime is on the patient's body. So advise the patient not to wash. Don't get a shower as much as he or she will probably want to. Um, don't let them go to the bathroom if they can help it. Any of that, because it can and will destroy evidence. If oral penetration occurred, advise the patient not to eat, drink, don't brush their teeth, again, as much as they're going to want to. Don't let them use mouthwash until after their exam, and their exam is done by the doc. Handle the patient's clothes as little as possible. You don't want your fingerprints on anything that you can help. Make sure you should be wearing gloves anyway, but try not to mess anything up, because all of that is going to be documented as evidence. Every ripped clothing, every stretch of cloth and all that. So again, we with the whole trauma naked thing doesn't apply here. Don't use, if you can leave it alone, leave it alone. Don't use plastic bags, because mold can grow and destroy evidence. That's actually something new in this curriculum. I've never heard that, but it makes sense. Put it in a paper bag if you can. And put it in something, because you don't want to. If you just left it loose, I mean, if it's on your patient, that's fine. But if they've got clothing laying next to them, put it in a paper bag. Make sure that the EMT caring for the patient is of the same gender as the patient, if it's possible at all. Um, it's not always the case, but just if at all possible, do that, even if it means taking a little bit more time to be out there. Treat medical injuries and provide privacy, support, and reassurance. Again, your patient is going to remember not what you did to help them, because there's not a lot we can do, but they will remember everything about how you treat them. And again, you may see them again in court, not you being on the stand as the defendant, but they're going to call you in there to get your take on what you saw. Um, Pretty much everything from your professional opinion, and what they may try to get you to talk about what you considered and stuff like that. I don't know, but make sure you document properly. Everything needs to be documented properly in this. But that's it. That's a horrible way to end a chapter. Any questions on what we covered tonight while I pull up your pen? Nothing? Okay. All right. Your pin for the night is Bravo Charlie 30A is an alpha. So BC 30A. I'm not entirely sure. You guys go back and double check, and I will as well, but I believe this might be the last chapter for trauma. So if that's the case, if I'm right on that, that means your modules are going to be due here in a couple of days. Today is Thursday, which is good because that means you have the weekend. You know what? Let me see. It'll take me just a second to pull it up. It is? Okay. All right, then yeah, I'll go with that. I was pretty sure it was. I mean, chapter 30, we only have I think 3 chapters left. Special populations is just peds, um, elderly, and OB. So we're almost done. The lectures are almost done. Make sure you guys are caught up. Most everybody is only a couple chapters behind if they're behind at all. So, oh, okay, we do have one more then. All right, cool. Either way though, I know we're nearing the end of it. So if you are behind, I know some of you guys are like 5 chapters back, 4 chapters back. Start trying to catch up because we're closing out this module soon. But that's all I got. If there's no questions, then we'll go ahead and call it a night. And I'll see you all on Tuesday.